Today's class is Diseases of Eyelids Part 2. Today we will discuss about edema of the eyelid. Due to the looseness of the subcutaneous tissues, the lids may be edematous easily. The edema of the eyelid is of two types. 1. Active or inflammatory edema. 2. Passive edema. First one, active or inflammatory edema. Again classified. A. Edema due to inflammatory condition of the eyelid. B. Secondary to other inflammatory conditions. The second one is passive edema. It is due to congestive cardiac failure, renal failure, cavernous sinus thrombosis or angioneurotic edema. Edema due to inflammatory condition of eyelid that include external hordeolum, internal hordeolum, blepharitis, lid abscess or cellulitis of the lids, and insect bite. Stye. It's also called external hordeolum. It's an acute staphylococcal infection of lash follicle and its gland of Zeus or mole. Symptoms of stye include tender, inflamed swelling in lid margin, single or multiple, may involve entire lid margin. Treatment: treat with hot compressors, removal of eyelash or systemic treatment in severe cases. Drain if pus points. This is a picture of stye or external hordeolum present in the upper eyelid. Chalazion, tarsal cyst or meibomian cyst. It's a chronic inflammatory granuloma of meibomian gland, blockage and accumulation of secretions. One or more glands involved, mainly seen in children and young adults. This is a picture of chalazion present in the upper eyelid. Signs include small, cystic, hard swelling, a little away from the lid margin, fixed to tarsus, non-tender, no signs of inflammation, no lymphadenopathy. Small chalazion may resolve or may remain the same. May burst on skin to form fistula. May infect and form internal hordeolum. Treatment is surgery. If the chalazion is small, leave alone the small ones. So here in this picture you can see the signs of chalazion, painless roundish firm lesion within the tarsal plate, may rupture through conjunctiva and cause granuloma. Histology of chalazion: multiple round spaces previously containing fat with surrounding granulomatous inflammation. Epithelioid cells, multinucleated giant cells are also seen. Next is blepharitis, common bilateral symmetrical condition. 1. Anterior form. It is usually because of staphylococcal infection in seborrheic patients. 2. Posterior form. It is associated with meibomian gland dysfunction, also called ocular rosacea. Blepharitis is usually a chronic infection of the lid margin. It is a common external eye disease. Causes of blepharitis is not clear, but staphylococcal infection and seborrhea is seen. It is associated with tear film instability. Chronic marginal blepharitis. It's of two types, anterior and posterior. Anterior again divided into staphylococcal and seborrheic. Posterior again divided into two, meibomianitis and meibomian seborrhea. It is a picture of anterior blepharitis. Staphylococcal anterior blepharitis. It is the chronic infection of the bases of the lashes resulting in tiny intrafollicular abscesses. Secondary dermal and epidermal ulceration and tissue destruction. More common in children but may affect any age group. Females more affected than males. Unhygienic conditions and dietary factors are also involved. Symptoms of staphylococcal anterior blepharitis are soreness of lid margin, lacrimation, itching, and photophobia. Signs include yellow crust at the roots of the eyelids. On removing the crust, small ulcers may appear. Fall of the lashes, either not replaced or abnormal replacement. This is a picture of bacterial blepharitis. In staphylococcal blepharitis, chronic irritation causes scales around base of lashes, which is known as collarettes. Hyperemia and telangiectasia of anterior lid margin, scarring and hypertrophy are also seen in long-standing cases. Seborrheic anterior blepharitis. It's a disorder of the glands of C's and mole. Seborrhea may involve scalp, eyebrows, nasolabial folds, retroauricular area, and sternum. Oily type and dry type are also seen. Dry type is also known as true seborrhea. Symptoms of seborrheic anterior blepharitis include less severity, discomfort in the eyes, lacrimation, tear film instability which causes stinging. Signs include shiny, waxy appearance of the anterior lid margin, dandruff like desquamation lid epidermis, yellow greasy scales. Treatment include lid hygiene, artificial tears, scalp treatment with anti-dandruff lotions. This is a picture of seborrheic blepharitis. In this picture, seborrheic blepharitis, you can see shiny anterior lid margin, hyperemia of lid margin, greasy scales, lashes stuck together. Complications, if not treated, may lead to poliosis, madarosis, trichiasis. Treatment, general treatment include improvement in general health, balanced diet, correction of refractive errors. Local treatment include artificial tears, treat the sequelae. Posterior blepharitis may present as dysfunction of the meibomian glands, isolated meibomian seborrhea and primary meibominitis, combination of anterior seborrheic blepharitis and meibominitis. This is a picture of posterior blepharitis. Primary meibominitis, diffuse inflammation around glands. It's associated with acne rosacea in 2/3 of cases or seborrheic dermatitis in 1/3 of cases. Signs, pouting of gland orifices with dome of secretions, may become solid, toothpaste-like. Obliteration of ducts, dilatation will be present. Thick, round, vascularized, notched, posterior border also can be seen. This is a picture of meibomianitis. In this you can see thickened posterior lid margin, meibomian cyst formation, etc. Meibomian seborrhea, dilated meibomian glands, easily expressed. Tear film is oily and foamy. In severe cases, meibomian foam at the medial canthus also can be seen. This is a picture of meibomian seborrhea. In this picture, you can see oil globules over meibomian gland orifices. On the other picture, you can see oily and foamy tear film. Treatment include A. Systemic treatment, B. Others like lid hygiene, topical steroids, artificial tears, etc. Local measures include warm compresses, mechanical expressions of secretions, etc. Complications include trichiasis, madarosis, poliosis, recurrent styes, marginal keratitis, tear film instability, etc. Next we will see lid cellulitis. Etiology include multiple styes, insect bites, trauma. Clinical features are whole of the lid is involved. Tender induration may lead to abscess formation or skin necrosis. Treatment is drainage. This is a picture of lid cellulitis. That's all for today. Thank you for listening. See you in the next class.